Good morning, everyone. It's nice to see a fairly good turnout on such a gray, gloomy day. And we're going to talk about something that we kind of expect to think about on rainy, humid types of days, mosquitoes and the Zika virus. So this is something to borrow a really nice pun that I heard this morning from Dr. Chang. She said this is a topic that's getting a lot of buzz. So we've all seen news reports on it. We've all seen the fears over Zika in Brazil with the Olympics, and it's something that our patients might be asking us about when they come for pre-travel assessments to pharmacies. So I'm just going to give a really, really brief overview of what Zika is and what we need to know in community practice, essentially, for the most part. So our objectives today, we're going to go over the regions where Zika virus is currently actively transmitted. We're going to address prevention measures for patients who are traveling to Zika-affected areas. Describe, of course, the risks related to pregnancy. That's one of the biggest concerns that are out there. And defining the symptoms of Zika infection so that we can recognize if it might be happening and know how to appropriately treat it. What is Zika? So it is a virus that is related to dengue, yellow fever, Japanese encephalitis, and the West Nile viruses. And in February of 2016, the World Health Organization did deem it to be a public health emergency of international concern. And this was for a number of reasons. So there was the cases of microcephaly that were being detected in the cluster areas where Zika was active. There's a lack of a vaccine for it. There's lack of treatment specifically for it in terms of antivirals. And also, there's really not anything super definitive in terms of testing for it. So with it being declared a public health emergency, that really did divert a lot of resources towards research in this area and data collection so we can understand this virus and its consequences. The current outbreak that is going on actually originated well over a year ago, even though it didn't really get much attention until the Olympics started to come up in Brazil. But it was first detected there back in February 2015. And now we've got 60 countries and regions around the world that are affected with it. So the next slide is from the CDC, which goes over the areas that have active mosquito transmission of it. So this is not including person-to-person transmission. So we do have some cases of person-to-person transmission in Canada, but these highlighted countries are the ones where it's mosquito-driven. So in terms of the United States, they've shaded in the entire country, but it's really only in Miami. So there's 3 regions within the city of Miami that have active Zika transmission. So we only have to really worry about that. However, pretty much Mexico, all of Central America, all of our Caribbean islands, and all of South America with only 2 exceptions. So Uruguay and Chile are the only 2 South American countries that haven't had reports of active virus transmission. If we look into Asia, Singapore is the only country to currently have that status. It was as of August of 2016, so it's quite new that it's made its way over to Southern Asia. The South Pacific Islands, and then if we look over to Africa, the Cape Verde Islands are the only ones that are affected. So a really easy rule of thumb is pretty much everything from Miami south with a couple of exceptions. So of course, with winter travel season coming up ahead, lots of patients are going to be going to Dominican Republic, Mexico, Cuba. This is something we should be counseling them on when they're coming and getting travel-related services from us. In terms of where it will be next, so like I said, Singapore is relatively new. Up until then, it was clustered in the Central and South America region. And there was a study that was just published a couple months ago in the Lancet where they did modeling studies looking at travel patterns for people traveling throughout the world and weather patterns. Because the mosquito that transmits the West Nile virus is quite weather dependent. It likes the tropical, subtropical climates. So what they did is they molded both of those 2 together into a model, and they're trying to predict where Zika is going to be next. And we're looking primarily in the areas in Asia. So India, China, Indonesia, Philippines, and Thailand were all labeled as being high risk of being the next places that Zika is going to go to. So this is something to keep in mind if we have patients who are traveling back to visit family in those countries or going there for travel purposes. We might want to be informing them that Zika is a potential risk there, even though it hasn't been confirmed yet. What about Canada? So the species of mosquito that transmits the Zika virus, it likes tropical and subtropical areas. Obviously, Canada is not a tropical or subtropical area. So the risk of mosquito vector-driven Zika here is very, very low. So the government, public health isn't saying it's impossible, but it's pretty much impossible. If you look at the regions where the 80 species of mosquitoes tend to live, so southern US, and creeping maybe a little bit into potentially very, very southern Ontario there, but again, very, very highly unlikely. So if patients come concerned about catching Zika in Canada, it's only going to happen if they catch it from another human. It's not going to happen from a mosquito. Transmission, this is something that we're probably all well aware of. So anything that involves blood and bodily fluids. So bite of the infected mosquito is, of course, the primary way that people contract Zika virus. There is evidence of sexual transmission from both males and females. We'll go over that a little bit more when we talk about sexual transmission prevention of this infection. Vertical transmission during pregnancy, obviously a big concern. And then blood transfusions, needle sticks, and organ transplantations. One thing that you might want to be aware of is that Canadian Blood Services has now implemented a 21-day waiting period for giving blood between traveling anywhere outside of Canada, the continental US, or Europe, because of wanting to keep the blood supply free of Zika. So if you are planning on traveling and you donate blood, you are going to have to wait for 3 weeks before they will take blood samples if you've gone to those affected areas. But what we're going to focus on is, of course, what's most common and what our patients are probably going to have questions about. Starting off first with mosquito bite prevention. So this mosquito is mostly active during the day, which is a little bit counter to what we tend to think. We usually think of putting on mosquito repellent at dusk and in the evenings when mosquitoes are active. These ones like the hot weather, they like the hot temperatures, so we have to tell the patients to be protected during the daytime as well as into the evening hours. Of course, physical measures you're probably all familiar with, so long clothing that's tucked in, so you have shirts tucked into pants and pants tucked into shoes, screens on windows and doors, and mosquito netting. I saw a really good reminder about mosquito netting that it is ineffective if it's touching your skin. Of course it is, right? Some people will drape mosquito netting over their bed if they're traveling or in a hostel or something, and it's not providing that physical barrier. So one thing to remind your patients of is that it shouldn't be touching your skin if you're draping it over your bed. To make a tent out of it, tuck it under the mattress and keep yourself fully protected. Of course, using mosquito netting on playpens, strollers, anything like that to keep the kids protected as well is something we'll want to tell our patients of. And of course, eliminating standing water sources. And DEET containing repellent is the most recommended measure according to CDC and Health Canada. There is some alternatives out there, but we'll cover DEET because it's probably the most common thing that we're going to be recommending. Concentration-wise, 5 to 35% is the range that we tend to see, but more isn't always better. It's kind of like sunscreen where we do see a plateau of effectiveness at a certain point. So anything above 30%, there has been some evidence showing it's really not that much more effective. So we don't have to necessarily go for the highest concentration we can possibly find. What concentration is associated with is the duration of effect. So some of the family products that only have 5% or 10% DEET will have to be reapplied every 2 hours, whereas like the Deep Woods that has 30, 35% can go for 3 or 4 hours before you need reapplication. So that's where the concentration part comes in. In terms of use in our more vulnerable populations, perfectly safe in children over 2 months, and in pregnancy and lactation as well. So there's no fears about using those. Counseling on them, this is probably review from some of your self-care things that you learned in pharmacy school. Of course, we want to recommend avoiding combination sunscreen and repellent products because our sunscreens have to be applied liberally and frequently, whereas the repellents we want to apply a little bit more sparingly and a little bit less frequently because we don't want accumulation of it. So you run the risk of overdosing on the repellent if you use a combo product. When you are using them separately, the sunscreen goes on first with the repellent going on second. And just like if we're dosing like acetaminophen and ibuprofen at the same time for a child, you have to follow the labeled directions of frequency for each separately. So keep that in mind, but if they are being applied concurrently, say first thing in the morning, the sunscreen goes on first. And there was some systematic review evidence looking at some of the alternatives. So the wristbands that are soaked in DEET repellent, some of the botanical products, and I've certainly received questions from patients about garlic and B vitamins repelling mosquitoes, and there's no evidence yet to show that that's effective at all. So right now, DEET and picaridin as the alternative. That's in some of the more family labeled products for parents who might be afraid of DEET. It is an alternative. It is recommended by Health Canada as an alternative to DEET. So DEET preferentially, picaridin second. In terms of sexual transmission, so the virus has been detected in vaginal secretions for up to 11 days, and it persists in semen for months. There's no real defined end date there. I've seen everything from 60 days, 30 days, 90 days. They're just kind of leaving it broad. It's months. It's a long time. We're going to want to be extra careful with men. There is evidence of transmission from both sexes and various routes of sexual transmission. And we know that the Zika virus really likes neurodevelopmental cells, and that's why we see a lot of those neurodevelopmental consequences in the fetuses that are born with Zika. So that's why we have to be extra careful with both men and women who may be affected that are in that childbearing potential age. So microcephaly is the one that's got the most media attention. So of course it's an underdeveloped skull and an underdeveloped brain. However, we do also see increased reports of fetal growth being less than what it should be for the age, as well as fetal loss. And we can also see some consequences on the hearing systems and the vision systems as well. So microcephaly gets the most press, but there is more to it than that. So even if ultrasounds look fine in terms of the head size, we are still concerned about some of those other neurological consequences. Current recommendations. This is where things get a little bit confusing. So we'll cover it in little bits. So women who are of childbearing potential, let's assume they're traveling alone. They're not going with their partner. We recommend that they delay any non-essential travel. Of course, that's going to be a tough sell for people that want to get away in the wintertime. But if they do decide to travel, we are to recommend postponing pregnancy if possible for at least 2 months following travel to the affected area. So remember, the virus tends to not stay as long in the vaginal secretions as it does in the semen, so that's why we have the 2-month recommendation here. As soon as we look into males, we know it lasts longer there. So they are asked to abstain or use condoms for 6 months. So of course, if a couple is traveling together, you're going to want to use the greatest of these 2 recommendations, right? So they should probably be waiting for 6 months because you're going to want to be protected from the male side of things. So if the woman is traveling alone, 2 months is fine. If the woman's partner is traveling as well, up it to 6 months. Clear? All right. If a patient is already pregnant and they're going on a baby moon before the baby arrives, it is recommended that they use condoms for the remainder of the pregnancy. So the majority of the fetal malformations are detected in the first trimester, a little bit in the second, but what we don't know is if a patient is infected in the 3rd trimester, are there neurodevelopmental complications that show up later in childhood, right? Are there learning disabilities? Are there language problems? Things like that, we don't know. So we recommend condoms throughout the entire duration of the pregnancy. And of course, this is in addition to traditional methods, DEET repellent. Breastfeeding. So this is a little bit controversial. There has been Zika virus detected in breast milk samples of lactating mothers who have been infected, but when they tried to culture it, none of them survived the culturing process. So it's a theoretical risk at this point. They are finding that it's present, but it's not viable type of thing in the breast milk. There have been no cases of infants who have been breastfed contracting Zika through that process. So therefore, the CDC says that the benefits outweigh any of that theoretical risk at this point in time. In terms of symptoms and assessing our patients, so we can look at up to a 2-week incubation period for Zika, with the symptoms generally lasting about a week. But the vast majority of patients are asymptomatic. Only 1 in 4, 1 in 5 will actually present with any symptoms. So especially in pregnancy, being symptomatic is not a marker of being infected and whether they should be concerned. In terms of distinguishing it from dengue and chikungunya, there are a few main things here to focus on. So a rash is almost always the first presentation of Zika. Starts in the face and moves down towards the body. It's much, much less of an issue with the other 2. Conjunctivitis also is unique to Zika. So if a patient's complaining of many of these symptoms and their eyes are affected, it's probably Zika over some of these others. And the reason why we want to rule out dengue and chikungunya is because they're transmitted by the same mosquitoes. And so symptoms are very similar, transmission is by the same mosquito, so we really have to do that differential to figure out the difference. Fever tends to be less pronounced in Zika, but arthralgia and myalgia tend to be much more pronounced in the other 2. So just something to keep in mind, look at the severity of the fever, whether there's a rash, and whether there is ocular involvement. So I came up with a quick little table. This is probably relatively straightforward. This is not from any official source. This is something that I developed, so please interpret it that way. So I was just thinking through a thought process of what would I ask a patient if they came into the pharmacy and I wanted to see if they had maybe come into contact with Zika. So 2-week incubation period, if yes. Are they currently symptomatic? If not, there's no point testing, there's no point doing anything. Because most of our patients are asymptomatic, most of our patients, it's just self-limiting infection and it'll go away on its own. But if they do have any of these symptoms, so a relatively low-grade fever, muscle and bone aches, headache, the conjunctivitis, all of that stuff, if it's not present, it's probably not Zika. It might be dengue or chikungunya or malaria. But if it is present and we also see the high fever and the severe myalgia and arthralgia, then we're going to be concerned about the other conditions especially. So it's kind of your judgment and the patient's judgment. Zika, if they want to get tested, it doesn't really affect treatment. It doesn't necessarily affect outcomes, but certainly if they've got some of the other infections, you want to be getting those tested for and managed. In terms of diagnosis, of course, clinical system and travel history. Laboratory testing is available for the Zika virus. It's available through our national laboratory, as well as quite a few of the provincial labs will do Zika testing as well. They'll look for the RNA of the Zika virus, which is only present short term, 7 to 10 days. After that, you may get negative tests, even though the patient is positive for it. However, the antibodies test positive for months. So usually they'll test both of those together to see if either of them are elevated. In the US, it's a notifiable disease. In Canada, it's not. So any statistics we do have of the number of infected people are not necessarily accurate. They're going to be an underestimate because most patients aren't going to get tested. And patients receiving a yellow fever vaccination before they travel may test falsely positive. And that's because yellow fever and Zika are related, and they do sometimes have overlapping positive tests. So do warn your patients about that. So it's a little bit of a diagnosis of exclusion, but it's also a bit of a messy diagnosis to make. In terms of management, that part is relatively easy. Supportive, yeah. That part I haven't looked into in huge detail. I do know there's a lot of overlap between the viruses, so the specificity is a little bit low. The sensitivity, I haven't come up across very much saying what level it's at. I think it's still relatively new. The US will certainly have more data on that because they're mandatory reporting there. But good question. Management, relatively easy. Symptom management, breast fluids, and acetaminophen only. We have to stay away from ASA and other NSAIDs because if the patient does happen to have dengue instead of Zika, there's a risk of hemorrhage associated with that. And you don't want to be adding to that risk by giving them an NSAID. So that's probably the most important thing we need to be aware of in community pharmacy is if there's any chance that they have this, it's acetaminophen only until they can rule it out. Guillain-Barré is a common consequence of this. So if we look at the incidence in the general population, it's normally about a little over 1 case per 100,000. As soon as we look at the population that's tested positive for Zika, it goes up significantly. So while it's still a relatively rare consequence, within the Zika population, it's a lot more common than it otherwise would be. So this is still at an association level. It hasn't been determined to be causation yet, but it's looking highly likely. And it requires immediate referral if it's suspected, because 5% of patients, even if they're treated perfectly and recognized immediately, will still die from it. So it's something that regardless of the severity, as soon as you suspect this, refer them on. The risks associated with it are usually due to autonomic dysfunction, so patients will have respiratory failure, cardiac arrhythmia, seizures. Those are the consequences that can make it deadly. But the way that it usually presents in practice is bilateral leg weakness. So make sure you tell your patients if you're counseling them on traveling to these areas that they know if you get bilateral leg weakness within 2 weeks, 6 weeks, give them a little bit of a buffer period after travel. That might be Guillain-Barré, you might have Zika and just not be symptomatic for the Zika, but you can still have the Guillain-Barré. Yep. That's a very good question. No, I think it's coming. They're doing a lot of data crunching in the US and in South America trying to figure out this stuff, but a lot of this is just at the association level. They haven't really been able to do a ton of differentiation yet. So that's what makes it a little bit murky. That's why just refer. As soon as this comes up, just refer, and they're probably going to test for everything. So just like if they're getting blood tests, they're going to check for malaria, they're going to check for dengue, they're going to check for everything. So at this point, it sounds like they're being extra thorough. But it's a good question. And we're reaching the end. So in terms of keeping current, Health Canada is certainly where you want to go to find out the status of Zika in Canada, but it's honestly not the best source for clinical information. If you want clinical guidance, the CDC is the place to go. They actually have training modules specific for clinicians that go over everything about treating it in pregnancy, prevention, all of that type of thing. World Health Organization and the European Center for Disease Control are also options, but again, I very, very highly recommend the CDC website for any info on that. They're certainly the most current and the most comprehensive, and they have a healthcare professional section specifically for us. So, any questions? It's a pretty quick overview. Yeah?
Do you have an idea of what's the incidence of microcephaly?
That's been quite a bit under debate because a lot of the patients aren't being tested for Zika. So they're developing microcephaly, the patient's being born with microcephaly, or it's detected on ultrasound and they're not doing the blood work in some of the countries that don't have the healthcare resources. So that's another big challenge, is that a lot of the countries that are affected by this don't have the same resources that we do. So if this was a North American issue, an Australian issue, a European issue, we'd probably have a lot more data on that. But we know we're not capturing all of the cases with blood confirmation of testing. So it's variable. Like all the stuff I read has given such a massive range that it wasn't even worth for me trying to see which one is the point estimate. Yeah. That's an excellent question. So the virus itself has been around since the 50s. It's not a brand new virus, but it never really got a lot of press, a lot of attention. It was one of those things that it was self-limiting, people self-treated, and it went away. And so there wasn't laboratory confirmation. There wasn't studies looking at longitudinal outcomes of it. People just thought it was like us catching a cold type of thing if you're in a tropical area. So that's going to probably come out of this 2015 outbreak. But in terms of any longitudinal data, the earliest I could find was back from 2007 when there was an outbreak going on. But even that's only going to capture less than 10 years, so we don't quite know yet. That's why the third trimester is still important for us to protect patients against, because we don't know if they're going to have learning disabilities or anything like that. So that's what's making this a really big challenge, is a lot of it is still unknown, unfortunately. Yeah, that's okay.
So I use travel assessments in my plan.
Yeah.
And I, when we were doing a job during the we're leaving to countries like Thailand and Philippines, there are high risk of Zika,
Mm-hmm.
transmitted endemically.
Mm-hmm.
And just looking at Singapore, I would say like, well, if it showed up on March 1st, 2016, likely was there for months before we detected it. A place like Singapore was probably detecting it. They're trying to test for it very frequently, and other places maybe not so frequently.
Yeah.
So do you have an idea of, essentially, because I have patients that are traveling to Thailand, and then 3 months from now, they found the first cases of Zika,
Mm-hmm.
and let's see, now they're pregnant, 4 months pregnant, 3 months pregnant rather, and then
Yeah.
should they get tested for Zika? You're saying the RNA can be detected.
The antibodies can be detected, yeah.
Plus
Yeah. So the CDC guidelines for treating it in pregnancy do recommend being extra cautious. So they're pretty much, if there's any chance, any risk going into their travel history that they may have ever been in contact with Zika during the course of the pregnancy, or even for, a month or two before, because it does linger in the system, that they're recommending testing for it, just to be sure, so that you do more frequent ultrasounds and you're doing more frequent follow-up to see if there are consequences. So it looks like they're being very, very comprehensive with it. But yeah, in terms of where it's going to go next, it's probably a good idea just to recommend anywhere that this mosquito lives, so anywhere that's a temperate, tropical type of environment, like you said, it's probably been there well before it's been detected. Yeah.
So if they go there, be conservative to say wait for 2 months.
Yeah. Yeah. Or at least provide them with that information so they can make that risk. But if somebody was saying, I'm going on a trip to Thailand, I would probably follow Zika precautions. Yeah. Yeah. That's a really good question. They have certainly done that in Central and Southern America for mothers who have had it detected on ultrasound. It's been provided as an option if they're within the window. So some pregnancies have been terminated for it. Sometimes the fetus passes away before it's born. There is increased risk of miscarriage in that population as well. So it is something that they are having that discussion with mothers. Lots of them are choosing to go forward with it and recognize that there is going to be developmental delay and health challenges in there. But yeah, it is something that some mothers have chosen.